go. Hi, I'm Sharon Anderson, president of Leiomyosarcoma Support and Direct Research Foundation, or LMSDR for short. And we are thrilled today to have Dr. Kristen Ganjoo from Stanford Medical Center here with us today to talk about making decisions, treatment decisions, something we all have to do. And I don't know if this is such a popular topic or if Dr. Ganjoo is a superstar, but we have 130 people registered today. So hopefully we'll have a very lively question and answer session. So without much ado, I'm going to let you take it away, Dr. Ganjoo.
Thank you. Thanks everyone for joining. It's really exciting to see you guys, and I know half of you, I guess. And I'm going to share my screen. I prepared 3 cases. I don't know if you guys can see this. Can you guys see my screen?
Yes.
Okay, good. I have 3 cases that I'm going to discuss, and these 3 cases will talk about when to do chemotherapy, when to do hormonal therapy, when to do radiation or ablation or chemoembolization. So I wanted to kind of go through just these 3 cases. Okay, I'm trying to figure out how to advance my slides. Oh, here. So if you look at the estimated US cancer cases in 2024, you will see all cancers, there's about 12 million cancers that will be diagnosed in 2024. Soft tissue sarcomas are about 1% of all these cancers, and this amounts to 13,590 cases. But when you look at leiomyosarcoma, which is about 15% of the 1% of all cancers, is about 2,000 cases a year. And this will tell you that, how rare this is, and why patients all have to go to a sarcoma specialist. It's because it's just so rare. And if you have a medical oncologist out in the community, they see 1 or 2 cases a year. So this is really important. The options for treatment are several. The gold standard is cytotoxic chemotherapy. Cytotoxic chemotherapy kills tumors at the DNA level, or at when they're multiplying or dividing. And these are just gold standard. We have doxorubicin with or without ifosfamide, which is the most common type of chemotherapy we use. Then we have gemcitabine, taxotere, or docetaxel. Then we have dacarbazine, temozolomide, trabectedin. There are a lot more than what I have here, but these are the most commonly used. And then as far as targeted therapies, this is very important for patients to know, because I have several patients that are getting targeted therapy based on their tumor genetic mutation. And this is important because not all leiomyosarcomas are the same. So we have to make sure that we look at the genetic mutations, see what mutations are possibly driving these tumors to grow. And we can block those mutations, hopefully by delaying recurrences or making patients' tumors stable. Pazopanib is something that's FDA approved, and we've used it, and I've seen some really good responses in leiomyosarcomas, specifically uterine leiomyosarcomas. There's also anti-hormonal therapies. Some of the uterine leiomyosarcomas are driven by estrogen and progesterone on their surface, basically androgens also. And anti-hormonal therapy is important in some patients, especially those who have low-grade leiomyosarcoma. So that's really important. Then we have immunotherapy. The initial studies that we did showed that immunotherapy doesn't really work as well for leiomyosarcoma, but there was a uterine leiomyosarcoma case that was a study that was done by Suzanne George very initially with nivolumab, and it didn't really show any responses. But those are patients that were just picked, not handpicked, but everybody who came in with uterine leiomyosarcomas were treated. But nowadays, we have a little bit more information on which patients respond to immunotherapy based at the molecular level. So that's also very important to look at. Recently, there was a study with ipilimumab, nivolumab, and cabozantinib, which is a targeted therapy very similar to pazopanib, Votrient. And that study showed that actually some leiomyosarcoma patients responded, and I had a patient on for 2 years with immunotherapy and a targeted therapy together. So it's really important to kind of look at the tumor from a genetic perspective. And then the other options, these are local therapies. So radiation oncology, of course, we can do focused radiation. Sometimes they call it CyberKnife. Sometimes they call it Gamma Knife, which doesn't really involve a knife, but it's just focusing radiation to a lesion, to a tumor. Or we have external beam radiation that we can do. So this is also very important. Ablation techniques we've used a lot over the past 10, 15 years. And these are for patients who have, one tumor that is growing out of proportion to the other. So we can cryoablate them, which means freezing the tumor, or microwave them, or we can now, recently we've been using pulsed electric field where we actually electrocute these tumors. And so ablation is very important in patients who have localized disease that we cannot do surgery because, for example, there's 10 lung nodules, but all the lung nodules are stable on treatment, but then all of a sudden you have one that's mutated and is growing, and that one you can definitely do ablation for. Embolization is important for patients who have liver tumors specifically, and embolization is basically going in with a catheter. You go in the groin, you go up into the liver, and you squirt whatever you want to squirt. It can be alcohol, it could be bland alcohol embolization, it could be chemotherapy, so you can deliver chemotherapy directly into the liver, or you can use radioisotope, which means radioactive material in there to make sure that you get those that area. So this is mostly for patients who have just liver tumor that's growing, and not, everything else is stable. So, but this has been done as well for patients. Surgery is really, really important because sometimes we have patients who have had 5 or 6 or 7 surgeries, and that just restarts the clock. So if you have someone who has recurrence of disease, you do the surgery, you start some other treatment, and this will give them a longer duration of being in remission or having no, some very minimal symptoms. Now we are doing some radiation for leiomyosarcomas of the uterus with HIPEC, and HIPEC is basically high heated chemotherapy that we put into the abdomen after surgery, and we're going to be opening a study with PIPAC. It's for gynecological cancers that we actually put these so patients in the OR, we put these catheters in the abdomen, and with pressure, we push the chemotherapy through the cells that are in the abdomen to try to shrink them and make surgery possible. So some patients, the surgeon will say, well, no, this is too big, I can't really take this out. But they can go in and squirt this chemotherapy with high pressure, gets into the cells, shrinks the tumor, and then we can do surgery. City of Hope has a study like that, and we're actually opening up a 2nd generation study with multiple different chemotherapies in. So this is another option for surgery. So I'm going to talk about 3 cases, and these 3 cases will illustrate a lot of the things that I just went over. So this case number 1, and if you have questions, just go ahead and stop me. But here's case number 1 is a 34-year-old patient who came in 2005. She was 34 in 2005. And she had some removal of leiomyomas or fibroids. So she had removal of fibroids because she was bleeding. So they removed the fibroids. Okay, fine. And then in 2009, 4 years later, she was bleeding again more, and the fibroids were growing. So they did a hysterectomy in 2009, thankfully without morcellation. And these fibroids were removed. But when we looked at them under the microscope, we saw these fibroids were really a little bit necrotic, a little bit more actively dividing than a regular fibroid. So we usually call that, high-risk fibroid, right? So, but it doesn't meet the criteria for leiomyosarcoma yet. So then 4 years later, in 2013, she has abdominal bloating. And we do a CT scan, and she has several tumors in there. So she's got a 13-centimeter tumor, a 14-centimeter tumor, and she's got multiple implants throughout the, inside the abdomen. And we also saw some lesions in the bones. So in the lumbar spine, some sclerotic lesions that we didn't biopsy because there's no reason to, because they weren't causing immediate fractures or anything like that. So this patient went in to have debulking surgery. So when they did the debulking surgery, they took these bigger tumors out and all the stuff that they could see, but they were leaving some stuff behind because it was just too many little tiny spots. And that was in 2003. Interestingly, the tumor, when we looked at the pathology, it showed a low-grade leiomyosarcoma. So this is really important. And I've seen a lot of my patients are so educated. I'm so proud of them. They come in and say, "What's the mitotic rate?" So what is the rate of these cells dividing? Are they dividing a lot? Is it a high-grade tumor, or are they dividing slowly? So are they low-grade tumor? So this is really important. So if this patient got chemotherapy, we would say, well, chemotherapy really kills fast-growing cells, so it shouldn't really kill low-growing cells. So this is a very important distinction to see whether chemotherapy is going to work or not. Some patients will say, well, she already has bone metastasis, so does that make this tumor a high grade? But we never biopsied them, and these were just sclerotic lesions, and we thought, okay, maybe they're a tumor, maybe they're not. They're very tiny. We don't know what they are. It could be arthritis. So we just left that be. And the fact that patient didn't have any lung metastasis or liver metastasis, that also helps you say, okay, this is probably a low-grade tumor. And because it didn't get into the bloodstream to go all the way to the lungs or to the liver. So we kind of we just kind of said, okay, let's leave this bone stuff alone unless something grows too much. And it's important to also know that when you look at bone lesions in leiomyosarcoma, they're osteolytic lesions, which means that they eat away the bone, and the bone on the scan looks really like hollow, like a little hole, not really sclerotic. Sclerotic means that there's too much bone in certain areas. So this was a very important, but if you just kind of look through this, you're like, oh my God, there's bone metastasis and those kind of things. But I finally decided, okay, this is not bone metastasis. We're going to treat this as a low grade. So case one continued. We decided, okay, this tumor is started out in the uterus. It's estrogen receptor positive. And we decided, okay, we're just going to put her, because she had these residual tumors in the abdomen, we're going to put this patient on Arimidex. And Arimidex or letrozole, one of those drugs, they block. So this patient didn't have an ovary, right? Didn't have ovaries. So there's no estrogen production. But from your body, from androgens, these androgens are transformed into estrogen, and they can cause the tumors to grow. So she was placed on Arimidex. She was on Arimidex for about 8 years, which is really amazing for somebody who had a visible disease in the abdomen. And her scans were always, we couldn't see anything within the CT scans as abnormal. But in 2002, I was just monitoring her disease, and we do all these frequent scans. So I did a PET scan this time. I wanted to look for bones, and I wanted to look for other areas, because leiomyosarcoma can get into the soft, into the subcutaneous tissue. It can get on the scalp, anywhere in the body. So she developed this left pelvic tumor, which was about 3-4 centimeters. So I thought, okay, this tumor is most likely a similar tumor, and it's most likely, not resistant to the Arimidex that she's been on for 8 years. So we decided to biopsy it. So biopsy showed leiomyosarcoma. It was still estrogen receptor positive, but it's clear that this tumor is growing based on other factors, not the estrogen anymore. So at this point, I thought, okay, let's try temozolomide, which is a chemotherapy. It's a chemotherapy pill. We wanted to try it to see if it will work for this tumor, whether or not we should use it after surgery. So this patient was going to have surgery, but we just decided, okay, let's just test it out. So we did 4 months, 4 cycles of temozolomide. It didn't have any effect, and the tumor slightly grew. So then she had surgery in January of 2023. She had surgery, and this 5-centimeter tumor was removed. Interestingly, the estrogen was positive on this tumor, but it's clear that this tumor just mutated and it started growing. So then I said, okay, Arimidex has been controlling the rest of the disease, and the disease that was not being responsive to Arimidex was removed already. So this patient again had this low-grade leiomyosarcoma. So we went back on the Arimidex. That was in 2023. And this patient has been on Arimidex since then, and she has no evidence of disease. So this is really important case to illustrate low-grade leiomyosarcoma. Arimidex works, and even in intermediate grades or patients that are not clearly low grade, we can say, well, we can try Arimidex for 3 months if there's little tiny tumors, and we can see if it works. If it doesn't work, then we can say it doesn't work. So that's also very important to kind of think about the process and think about what's going to stop this tumor. So some physicians at this point where the patient had the surgery will say, well, this tumor came back and we're going to do some other treatment. But you just have to think about that tumor that grew, it's already removed. So you don't have to really worry about that tumor. And not all cancer leiomyosarcoma cells that are throughout the body will grow at the same rate, or they're not going to mutate with same mutations. So individual tumors are important. Does anyone have any questions about this case before we go to the second case? Or Sharon, do you want me to just go through the cases and then at the end? Because these cases are very complicated, but it's up to you.
I think we can take questions if people have them. I don't know if they do or not, but I have a feeling these cases are going to progress in terms of grade as we go.
Yes. Yes. So yes.
No
so
questions, anybody?
There's some comments.
Yeah.
So they said one of the comments is, why not letrozole? Yes, so we can definitely do letrozole. Letrozole, Arimidex are very similar. They're same class of drugs. And I have actually noticed that some patients don't tolerate letrozole. I put them on Arimidex, they tolerate it, and vice versa. Letrozole can probably give less joint aches for some patients. And it's very important, guys. If you are on letrozole, you are going to have to check a bone density, because that's one of the side effects. It causes osteoporosis. So vitamin D levels have to be checked, and bone density has to be checked every 1 year. So that's really important. The other things that we need to check are liver numbers, as well as cholesterol, triglycerides. Those are usually go up with letrozole, and it's important to check those as well. And Arimidex is just for uterine leiomyosarcomas. I've seen very few leiomyosarcomas that are estrogen receptor positive, but uterine leiomyosarcomas that are estrogen receptor positive are half of the uterine leiomyosarcomas. So we don't generally use them unless patient had a fibroid long time ago, like this case, and all of a sudden has all these pelvic tumors, and you check it and it's estrogen receptor positive, then you think, oh, it probably came from from the uterus. So yes, anything that's estrogen receptor positive, you can try these drugs. And it's important to know, if you have your ovaries left over, you have to, and you're not postmenopausal, you have to shut down the ovaries, because if you don't shut down the ovaries, this Arimidex will not work, because you just have all this estrogen that is being produced by the ovaries. So in those situations, patients will be on Lupron shots to put the ovaries to sleep, and then you take the Arimidex. And estrogen receptor of 90% does not indicate higher grade tumor. So estrogen receptor positivity does not have anything to do with the grade of the tumor. It just tells you that 90% of the tumor cells have estrogen receptor on them. If they're 50%, the pathologist says 50%, okay, so 50% of the tumor cells have estrogen on them. So the other tumor cells are being driven by something else. So that's all it means. It doesn't have anything to do with the grade. So if you have a lower estrogen value, which would Arimidex, would it work? It still can work if you have a 50% of the tumor cells that have estrogen receptor on them. But you have to be mindful that maybe you have to do a little bit of chemotherapy pills, like temozolomide. I really think temozolomide is a great drug for uterine leiomyosarcoma, so keep that in mind. And we can use those two together. Would an aromatase inhibitor be worth trying for grade 2? Yes. So aromatase inhibitor, Arimidex or letrozole, it is worth trying for grade 2 uterine leiomyosarcomas. Even for some slightly higher grade ones, I've used it and I've seen some stability for a while, but you have to monitor it more closely if it's a higher grade. You guys have great questions. Is it worth trying Arimidex for adjuvant setting? Yes. So this person had some disease left over in the abdomen, this patient, but in adjuvant setting, if the patient's tumor is really highly estrogen receptor positive, and you think, there's no data with this, okay? But if you think that this tumor is aggressive, so larger tumors or tumors that were being peeled off of the bladder or something that was a little bit more than just the regular stage 1 uterine leiomyosarcoma, I have given that in adjuvant setting when I'm worried that this patient may have some recurrences soon. So this can delay the recurrences. And please remember, we don't know if chemotherapy or any hormonal therapy will help the adjuvant patients improve their cure rate. So if you have stage 1 or 2 and you're giving chemotherapy or you're giving hormonal therapy, I think what this treatment will do is delay the recurrence in the 50% of patients that are going to have a recurrence anyway. So 50% of the patients will be cured with surgery, but another 50% will have tumors come back. So those patients, if you try adjuvant therapy, it delays the recurrence. It doesn't improve their cure rate, at least with the data that we have available. Would you recommend ovaries to be removed? Yes. So because Lupron, Arimidex, all these hormonal blockers can increase your risk of blood clots, sometimes when patients have multiple tumors that, and that they have their ovaries and they have multiple tumors, we give the Lupron short term for 6 months. And then if the Arimidex is working, then we say, hey, we need to go take these ovaries out because this is clearly the hormonal blocking agent that we're giving is clearly working. So let's get rid of that Lupron, which increases your risk of blood clots, and remove the ovaries. So that's good. But if you do Lupron and Arimidex or letrozole and it doesn't help your leiomyosarcoma, then there's no need to remove the ovaries, because at that point, we're going to say this leiomyosarcoma is not growing because of estrogen. So we can spare the patient a surgical procedure. Okay, and then the other, I can't read. Oh, how considerate you have been on the treatment, commendable. Oh, okay, thank you. That was just a nice comment. Okay, if you start taking letrozole when you first have lung metastasis, but the tumors keep growing, does that mean letrozole isn't working? Could you have new meds? Could not have, okay, yes. So the question is, if you have lung metastasis, but the lung metastases are slowly growing, and you're on letrozole, that means that the letrozole is working, slowing down the growing, as long as you don't have new lung lesions. If you have new lung lesions, then all bets are off. The letrozole is not working. You have a clone of leiomyosarcoma that is being that is growing based on different mutations. So
I'm wondering if we should go on to your next case, because it's
yes,
already
yes, those are all done. Yes.
Okay, great.
So next case. All right. So case number, my teaching points. teaching points was aromatase inhibitors may delay recurrence of estrogen-positive uterine leiomyosarcoma. For localized tumors, like in this case, surgery is the best option to get that out, that mutated tumor out. Aromatase inhibitors can be reused if the resistant tumor is removed, like we talked about, and not every patient needs chemotherapy. So I think we touched on that. And then our second case is a 70-year-old patient at the time, and she was 70 in 2002. She's 92 now and doing great. So this patient presented to us with leiomyosarcoma of the inferior vena cava, which is that big vein that passes through the liver and goes up to the heart, right? So this tumor was basically in the inferior vena cava, which is sort of the smooth muscle of the vein, and it had grown into the liver. So at that time, she had surgery. They removed the leiomyosarcoma, and they had to remove the right kidney because that was also in the way, even though the right kidney was not involved, but all the vessels that were going into it were involved. So that was removed. Then 16 years later, she was not on any treatment. There was no need to put her on treatment at this point. 16 years later, she has a regular PET scan, and there's 3 liver tumors. And she was getting, I wasn't doing PET scans on her at that time, 16 years later, but she had some right-sided abdominal pain. So we went ahead and did a CT, and then we did a PET scan, and it showed 3 liver tumors. And we biopsied one, which showed the same leiomyosarcoma. And this leiomyosarcoma was a little bit more higher grade than what we had before. So, and of course, it was estrogen receptor negative. So then in 2018, she had an ablation. She did a microwave ablation of these 3 liver lesions. But a year later, they started growing to the point that one was 9 centimeters, 8 centimeters, and 5 centimeters. So it did grow. So at this point, I told her, well, your PET scan doesn't show anything else in your lungs, any bone tumors. This is the only area that we have the leiomyosarcoma. So we went ahead and did radioembolization. And radioembolization is basically when patient goes into the procedure, they go in with the catheter goes in to the groin goes all the way up to the liver, and they squirt radioactive material. Just like I usually call this liquid radiation, which is just liquid instead of doing radiation from outside. And this really did help kill the tumors. And to this date, she has not had any recurrence. So this illustrates, and sometimes I see a lot of patients for second opinion, they come in and they're like, well, they told me I have stage 4 and I have liver tumors, and then they start the patient on chemotherapy. And we have to be we have to know all of these local therapies and how they can help. We published our data with radioembolization for our patients with liver disease. And for leiomyosarcoma is the ones that it did really work. And leiomyosarcomas usually respond well to radiation. So we noticed that patients who did very well with radioembolizations are the ones that have the majority of the tumor is in the liver. So it doesn't have to be, okay, the patient has 2 lung nodules, we don't want to do radioembolization. That's not the case. If patient has metastatic disease other places, and you do have patients on chemotherapy, for example, everything is stable except for the liver tumors are growing, you can still do radioembolization. So it doesn't mean that you just have to do it when it's only in the liver. So this patient is 92 right now, doing great. One of the complications of radioembolization, I don't want to miss that, is that this patient presented, I think it was 2020, with fevers. And what happens with this radioembolization is when it kills the tumors, they become a cavity. So they become like a dead cavity in the liver. So this patient had fevers, and the outside people did CT scan. They said, oh, your sarcoma is back. But when we looked at it, it was all full of pus. So it was just an infected, round, empty tumor, like dead tumor. So she got IV antibiotics, and after a week, she was taking PO antibiotics, and everything cleared. So it's really important to know that these treatments exist, but there may be some complications that is really not tumor coming back, but maybe something because of the procedure. So this is what happened to this patient. So my teaching points for this is radioembolization can control localized LMS in the liver. And, we can also think about surgery, but when somebody has 3 big tumors, then you can't really do surgery for that patient. It can also be used in metastatic disease if the main tumor area is in the liver and if the liver LMS is the main growing area in metastatic disease. So this is also important. When they do radioembolization, it's with the radioisotope, but we can also squirt chemotherapy in there that's called chemoembolization. So we can do chemotherapy. So the chemotherapies that we've used is gemcitabine, we've used doxorubicin. So those are the chemotherapies that we normally use for chemoembolization. Sometimes we can do radioembolization twice, depending on where in the liver it is, because they can go in right directly to that tumor. They don't have to put liquid radiation in the entire liver most of the time. Sometimes radioembolization can cause damage to the liver, because imagine you're giving liquid radiation to normal liver tumors. But the guys that do this, they're very good. They go in and to that branch of the vessel that is feeding that tumor, and they squirt it right there. So instead of kind of giving it to all the normal liver tissue. So any questions about focal therapy? So one question is, okay. All right, so it says, what is pretty clear on the CT that the masses weren't cystic, or were there doubts and that's why PET scan was done? Well, there were doubts, and that's why we did the PET scan. They were cystic, but some of this pus was kind of looking solid, so on the CT scan, it was really hard to see. So when you do a PET scan, you can see how much that area takes up the PET scan material. And we call that standard uptake value, or SUV. If the SUV is 20, that's not an infection. If an SUV is 5, imagine an SUV of 2 is a normal background for liver. So if you get SUV of 5, okay, it's an infection, inflammatory cells, they're lighting up the PET scan. But if the SUV is really high, then you know that's tumor and not infection. So I wanted to do that, but we ended up draining some of this liver pus as well. So we put drains in there and drained the stuff out. So the PET scan was kind of helpful because I wanted to see, is there anything else in the bones, or is there anything else in the, in the lungs or anything like that. So I wanted to scan the whole body, but that really did help me figure out this is not tumor and this is something that needs to be drained. And then it says, the other question is, can you do radioembolization on other IVC adjacent tumors? So yes, we have done that, but mostly we do bland embolization. So for example, if you have a tumor in the abdomen that we want to do surgery, but we're afraid this tumor is going to spill or rupture during surgery, we cut the blood supply to it with embolization. We call that bland embolization. So we do it, we send it in, it blocks the blood supply to tumors, and then the tumor kind of shrivels, and then it gets harder. So then you can do the surgery without being afraid that it's going to rupture. The problem with radioembolization and tumors in the abdomen is there's a lot of small intestine around that tumor. So that radioembolization, the radioisotope, the radioactive material will go to adjacent small intestine and cause problems with holes in the small intestine. So that's why we do the bland embolization with alcohol spheres for those patients who we want to shrink this tumor, and it's all the small intestine is around it. We don't want to produce holes, so we can't do radioembolization, so we have to do this kind of procedure. Another question is, I have a liver tumor in my hepatic dome. Yes, so radioembolization is very difficult for livers and hepatic dome because it's right, here's your hepatic dome, here's your diaphragm, and here's all your lungs. So it can cross over to your lungs and you can get pneumonitis. You can get pneumonitis, which is irritation of the lungs, and you can also get damage to that. So this is why, yes, cryoablation, and she's had microwave ablation. Are there any certain areas in the liver that where radioembolization is possible. Yes, so the way they do the radioembolization to make sure that what they're giving is going to the right place is they give you a test dose a week before. So that test dose is a little tiny bit of radioactive material, and they measure how much of it goes to the lungs. If more than 30% of it goes to the lungs, we cannot have radioembolization, because it means that your lungs will be irritated and you'll get pneumonitis. If a lot of it goes to the stomach, because sometimes people get stomach ulcers from this because the stomach sits right next to the liver. So that also they can tell based on that test dose. So the test dose is really important. It doesn't damage anything. It's just a very tiny little amount of radioactive material, but it actually tells you exactly where this material is going to go when you have your treatment. And then another question is radioembolization or ablation in the liver possible to do even if you have several mets in the liver, or if it's not possible to remove? Yes, if it's not possible to remove all the metastatic lesions in the liver, yes, radioembolization is an option. Ablation, remember guys, ablation is different than radioembolization. Embolization is when you access the tumor through the blood vessels. Ablation is when you stick a needle directly into the liver, into that tumor. So ablation is different. If you have 10 tumors, we don't want to stick tumors and, stick needles in all of these 10 tumors. But if you have 10 tumors, then the radioembolization makes sense because you're going through their arterial supply and you get all of them in one setting. So that's where embolization is better utilized. If the main tumor is a large retroperitoneal tumor, can you do radioembolization? We can do radioembolization, but again, you have to check and see if you have intestines around it or not. That's really important because also in the retroperitoneum, there's also kidney there. So you can accidentally give a lot of radioisotope to the kidneys. Is chemoembolization widely practiced? Would it be done in Australia? I am sure it's being done in Australia as well, because when we go to our meetings for our CTOS meetings or ASCO meetings, there are physicians there that do that as well. So I'm sure it's available in Australia. So let's go to case number 3. This is our last case. This is a 54-year-old patient who presented in 2015 when she was 54. She had postmenopausal bleeding. And she had, at that time, she had hysterectomy, bilateral salpingo-oophorectomy, so the ovaries were removed. And she had a high-grade uterine leiomyosarcoma stage 1B. At the time, we talked to the patient about adjuvant chemotherapy. We were worried because this is high-grade tumor and patient was very young. So we decided, okay, let's do the chemotherapy knowing that there's no data. Talk to the patient, if you want to be very aggressive, we can do chemotherapy that may delay the recurrence at some point. So we decided to do 3 cycles of gemcitabine taxotere. And then at that time, we did radiation because this tumor was high grade. We were worried that this was going to come back in the pelvis. So we did radiation and brachytherapy. Brachytherapy is when they go put little beads into the upper part of the vagina to make sure that it doesn't come back in that top part of the vagina. So then we did radiation therapy and brachytherapy. And then she had another 3 cycles of gemcitabine taxotere after the radiation. So everything was completed in 2016. Unfortunately, 2 years later, there was new lung lesions. And there was one tumor. So we decided, okay, we need to make a diagnosis, whether this is leiomyosarcoma or not. So we did a wedge resection, which means that they go in with scope, thoracoscopy, instead of cutting the whole lung, side of the ribs. They go with little tubes and cameras. They take this lung nodule out, and it did show the high-grade leiomyosarcoma again. And a year later, so we decided not to do anything. Let's just wait and see what happens, because we know in metastatic patients, you give chemotherapy. It only delays recurrence. It does not cure the leiomyosarcoma. So a year later, she had a new lung lesion. And this time we said, we don't want to put her through surgery. We're going to do a microwave ablation. So we did a microwave ablation and that tumor was destroyed. A year later, now here's the problem. We had some disease in the kidney. So now it's getting into the abdomen. So again, we removed partial section of the kidney that there was leiomyosarcoma on it. It was removed. And then we decided, okay, this is getting too common, so things are coming back too frequently. So we put the patient on pazopanib or Votrient. We decided, let's just do this. Let's try to delay the next recurrence. So in 2000, so she was on pazopanib, Votrient, for about a year. And then a year later, she had some lung nodules. So we decided to go ahead and try temozolomide. So she was on temozolomide for a year. And the way we do the temozolomide is they take it for 5 days, every 21 days. And it's a pill. It's easy. Patients like it. Sometimes if you use higher doses, patients will get nausea and vomiting, and it's hard for them to handle it. But majority of the time, some patients may have some lowering of the blood counts, which is rare. 1 out of 1,000 patients will have platelet problems, but most patients tolerate this very well. So while she was on temozolomide, we also did some microwave of one of the lung lesions that was growing, and we did CyberKnife or focused radiation to a T11 spine lesion. So it's clear to this point that, okay, we got this metastatic disease. This metastatic disease, it's very hard to control, and we're just going to have to zap anything that tries to get out of control while patient remains on treatment. So at that point, we had that clinical trial with immunotherapy and cabozantinib, which is similar to pazopanib, but we know that cabozantinib stimulates T cells. So stimulating T cells helps the immunotherapy. So this is a Brian Van Tine study that we participated in. So this patient was on this treatment for a year and did really well, except there was a tumor in the spleen that tried to grow and tried to grow. So at that point, we said, okay, let's stop this study and go and remove the tumor. So we removed the tumor, which was getting big and causing some pain. So the tumor was removed, and it was the high-grade LMS. So spleen was removed, patient got appropriate vaccinations. And then a month later, she was having a lot of bony issues, a lot of bone metastasis in the cervical area, the neck, shoulder, spine, right lung. So there were some tumors that were growing again. So at that point, I thought, okay, the patient has had some chemotherapy. Let's try, she's had gemcitabine taxotere. Let's try some other treatments. So we decided to start on Yondelis. And at this point, our patient was very concerned and was thinking about, okay, I don't want to have so much pain. I don't want to have pain in my shoulders and my bones. I want to take into consideration the End of Life Act. This was very tough for me to discuss, but we went through the process of End of Life Act, and I told the patient, okay, let's just try Yondelis, trabectedin, even though trabectedin can control leiomyosarcoma in very few patients, but sometimes when it works, it really does work. So patient agreed. And then between all of this, we also did some other things, other radiation and those kind of things. But patient had radiation here, pain was controlled. And then we gave patient Yondelis or trabectedin, which is a chemotherapy, is a 24-hour chemotherapy every 3 weeks. It's very important to know that some patients are very sensitive to this chemotherapy. So over the years, I've noticed that some patients will have organ failure, their kidneys fail, their muscles break down. So I have been very cautious to start at a lower dose for patients for the first cycle, just to see how the patient tolerates it. And then, and it's good that we did that because most patients cannot tolerate the full dose, and they have a lot of side effects, including nausea, vomiting. So we tried lower dose, and our patient was happy. She's been on it now for a year, and her tumors are responding, and she's one of those 10% of patients who Yondelis works for. So when patients are asking me about end-of-life act, I want to make sure that I can improve their quality of life. And I'm one of those physicians that works with patients, and I give the drug for end-of-life act because I feel that I've taken care of these patients for 10 years and I'm not going to give them to some other doctor to prescribe it. So I have it, I prescribe it, but I also tell them, what if I control your pain? Because bone pain is a very bad pain. What if I can control your pain? Will you let me give you this chemotherapy? So when the pain was controlled, the patient agreed and we did the chemotherapy, and now she's having a normal life, good quality of life for a year now, getting Yondelis. So that's really important to me because I want to be there for my patients until the very end, but I also want to make sure that I don't jump into end-of-life act just because patients are uncomfortable, and if I can control their pain and give them good quality of life, then that's what I would do. So teaching points: adjuvant chemotherapy for any kind of leiomyosarcoma, if it's uterine, if it's extremities, if it's IVC, any of that has to be discussed with patients because we don't have the data, and most of us think that you cannot cure that 50% that the cancer is going to come back, but you will delay the recurrence. So some patients will say, I want to delay my recurrence. What if it comes back in 2 years, but if I do chemotherapy, it comes back in 3 years? That's meaningful for them. So they need to decide on that themselves. Some patients will say, no, I don't want to lose my hair. If it comes back in 2 years, that's fine. I'll do the chemotherapy then. So it's really important to discuss with patients. We don't have the data, but this is what the chemotherapy will do based on our experience, and then they will decide. It's a joint decision between the patient and the physician. Ablation can be used for growing single lesions while continuing the same chemotherapy. So if somebody is on chemotherapy, every tumor is controlled. One tumor gets out of hand and you can ablate that tumor. You can kill it and that's it. Then you continue with the same chemotherapy. Radiation is effective, very effective for leiomyosarcoma for bone tumors, especially when the bone tumors are painful. Patients who have bone tumors should be on something like Zometa or Xgeva. Those drugs will get the calcium from your blood, shove it into the bone where there's a hole in the bone because you had the leiomyosarcoma eating away the bone. So that shoves in the calcium in there, makes new bone, that improves the pain, and it also reduces fractures. So when you have a hole in your bone, there's a high likelihood that there will be a fracture. If you jump up and down, the bone will break, and that is really painful as well. So then you need surgery and all of that stuff. So Xgeva and Zometa are the drugs to use for this to hopefully prevent fractures. And also consider clinical trials. I know Sharon is all about clinical trials. We're all about clinical trials. You have to make sure that every treatment decision that your doctor makes, you say, what about a clinical trial? Because if you go on a treatment, standard treatment, you have 3 treatments already. Some studies will say, no, you're supposed to only have 2 treatments. So then you lose your chance of going on that clinical trial. And all of these drugs we have, the Yondelis, Eribulin, all of these drugs have been through clinical trials. So right now, we don't have any trials for patients who have no disease. Like you did surgery, everything was removed. We don't have any studies for that. But we do have studies for patients who have a tumor in their leg that's leiomyosarcoma. We can do radiation. And interestingly, Stanford and some other locations, they have radiation for 5 days of radiation prior to surgery instead of the 5 weeks we used to do that delayed surgery. So some radiation oncologists will talk to you probably about the 5-day radiation therapy. So there's a lot of things going on in clinical trials, leiomyosarcoma being one of the most common subtypes of sarcoma. We have just massive numbers. And I think getting into what Sharon is going to help you find that clinical trial if your oncologist is not helping you. The other thing that I wanted to say is, here's a picture of Stanford. I just wanted to show you guys. I like the historical pictures here, these little old buildings. But you have to go to a sarcoma center. Imagine your tumor is so rare. It's even less than 1% if you have, a type, because sarcomas are 100 different types, and you're just 15% of the sarcoma. Sarcoma centers have medical oncologists that do the chemotherapy and treatments. You have surgical oncologists that are specialized in surgery. I was just talking to Dr. Posides. We shared the patient 15 years ago together. I mean, we've shared all these patients, but 15 years ago, a patient came to us on hospice with leiomyosarcoma of the uterus because she was losing weight. She had a tumor in her uterus that was removed, but then this tumor came back. It was 35 centimeters. So 15 years ago, the GYN oncologist said, let's put this patient in hospice. And I said, no, this patient's very young. She's 40. I'm going to talk to Posides. And Posides did the surgery. It was a 12-hour surgery, 10 units of blood. But she survived, and she is now disease-free 15 years later. And the amazing thing about this story is, even though like every 5 years she'll get just little tiny nodule, Posides goes in and just removes that little tiny nodule so it doesn't get big. But this was our biggest save in the past 20 years that I've been at Stanford. It was just amazing. So she doesn't even want to talk about leiomyosarcoma anymore. She's like, I'm doing well. So radiation oncologists also are very important in our team, because sometimes when the tumor is not resectable, we can do radiation, shrink it, and make it resectable. So they're also very important to our group. Interventional radiologists are the doctors that do the radioembolization and ablations. Sarcoma pathologists, you have to have your pathology reviewed at a sarcoma center. It's really important, because the regular pathologist over at a community hospital will see 1 or 2 cases of leiomyosarcoma a year. So you need to figure out what type you have. And multidisciplinary tumor boards. So tumor boards are important because all of these people are there, and you have a case. You discuss your case. You say, okay, what about if we do radiation now? Okay, talk to the pathologist. Are you sure this is leiomyosarcoma? What are the genetic mutations? So all of this is important for you guys. You have to make sure that you go into a sarcoma center, at least for a second opinion. So a lot of places don't have them, but at least for a second opinion. There's several ways to get second opinion if you're out of state. There's online second opinions through Dana-Farber, through Memorial, through Stanford, through MD Anderson. Everybody has online, where they give us all the scans, they give us the pathology reports, and then we kind of compile our recommendations. You can also go into a center for a second opinion so that they can see you in person. I always think that in person is better, because when you go in person, they also have to review your pathology. And but we're also very careful on the online. If we have any doubt on the pathology, and we say, okay, this is one of my recommendations, send it to such and such person so the pathology can be reviewed in detail, because when I'm looking at the report, I'm not really sure what this is. So so that was my presentation, I hope. And my case 3 patient is also here, and I don't know if she knows that this was her case, but yeah, so welcome, my dear. So we got some comments, I think.
Some questions in the chat.
Oh, in the chat. Oh, okay. Let me see. How do I lost my chat function.
I know, it's where the 3 little dots are, I think.
Oh, okay.
Where it says more.
So should I go into, oh, there it is. Okay, got it. So one patient says, are Stanford able to offer second opinion internationally? Yes, we do that all the time. You go through online, second opinion online. And I've done consults, second opinions for China, for a lot of different places. And Charlene says, oh, she just says, appreciate you. Thank you, Charlene. And then let's see what else. Thank you so much for the insights. Very informative. How can I take a second line opinion from Stanford Center? Oh, from Pakistan. Yeah, we do that. You just go online and just type in Stanford a second opinion, and then you go into the second opinion, you start your conversation with the intake person, and they collect everything. They collect your CT scan, so we're actually looking at the images. They collect your pathology reports and all of that stuff. I've done those for the Middle East a lot, so that's doable. And then Dan says, thank you. My mom, Martha, will be having her follow-up with you soon. Okay. Okay, Dan, we'll see you. And these are all just nice comments. Thank you, everyone.
Well, we do appreciate you so much. I believe this is such an important topic, and we need to be educated so that we can do our 50% of making decisions with our doctors. But the fact that it is our responsibility and our privilege to be able to be a part of the team. And the more we understand all the decisions, especially coming from the medical oncologist, the better we can participate. So thank you so much, Dr. Ganjoo.
No problem. There's one comment that I feel bad because it says, seems like very low proportion of males in LMS sample. So I didn't discuss any. We have a lot of male patients who have extremity sarcomas. Those are the most common types of sarcomas that they're in the legs or the arms. And we have patients who have leiomyosarcoma in the sinus, in the inferior vena cava. The samples I picked today was just to illustrate different ways of treating. So my liver patients could have been a male. So I'm sorry if I left the male patients out. And it says, do you have... Yeah, do you have room for a new patient? Yes, and now we have hired, we have 3 medical oncologists at Stanford Sarcoma Center and 2 nurse practitioners. So I take all the leiomyosarcomas. So I see the leiomyosarcoma cases, and the other cases I give to my colleagues. So at least they can see the other 100 types of sarcoma. So thank you, everyone. It was really fun to be with you guys on Saturday.
Well, thank you so much. It is such a wealth of information, and it's so important that we have all of this. So I want to thank you. Thank you, everybody, for coming too.